Our case study is on VP. VP is a 70-year-old male. He is a docent at the Native American History Museum. Mr. P enjoys spending time with his wife, 3 adult children, and 7 grandchildren. He's referred to an SLP by his oncologist with a history of thyroid cancer. He had surgery to remove the cancerous mass performed 8 months ago. For his case history, his major complaint is hoarseness and extreme vocal effort. Today, his voice is breathy and gruff and hoarse. He said his voice is also fatigued. Prior to his surgery, his voice seems strong and functional. However, after long days at the museum, it's described as tired and sore. VP says talking for long periods of time on the phone or to people in loud rooms makes his voice hurt, and says vocal rest helps his voice. He is also able to use a small portable microphone while working as a docent. VP says his comfort level is about a 6, with indication of it being worse the more he uses it. VP reports that his pain when speaking is at a 4 out of 10, with 1 being no pain. VP uses his voice about 60% of the day. VP has a difficult time socializing with his friends. VP's voice difficulties have made it hard for him to keep in touch with his grandchildren and children. It's difficult for them to be understood on the phone. He's unable to work as often as he did prior to the surgery. VP explains his vocal hygiene habits include little to no water intake, drink socially 5 to 6 nights a week, daily cup of coffee, and a former smoker. Currently, he's on thyroid hormone supplement and a medication for blood pressure, and he reports difficulty swallowing when his throat is sore or fatigued. VP's perspective, his major complaint is hoarseness and extreme vocal effort, and his goals are to have a strong and clear voice, to be able to talk without having to exert a lot of effort, and to be able to talk for longer periods of time and be heard. On his Cape V, his roughness is 70, breathiness 70, strain 20, pitch 0, loudness 50, and overall 70. His pitch is within normal limits, but notice severe roughness, breathiness, and moderate changes in loudness, with client's voice sounding too quiet and weak.
This is VP's initial data. He is within normal limits for most of his data, but notably he is below normal limits in jitter, intensity, max intensity, and MPFR. His aerodynamic data, he is above normal limits in subglottal pressure and PTP. His stroboscopy reveals that the mucosal edges are thin. There's an incomplete glottal closure. His open phase predominates over his closed phase. The moderately high mucosal wave, there's a decrease in the vibration amplitude. His symmetry is asymmetrical, and his periodicity is moderately aperiodic. The EEG shows that there is a long open phase and a short closed phase, which indicates a breathy voice quality. The EMG shows that the majority of the muscles are innervated and functioning properly. The EMG revealed that there's little to no activity of the lateral cricoid arytenoid, which is consistent with the incomplete glottal closure and breathy voice quality. So VP is a 70-year-old male who is 8 months post-surgery to remove a cancerous mass on his thyroid. He experiences moderate to severe hoarseness and vocal effort. The Cape V assessment revealed to have moderate to severe breathiness and roughness and a moderately decreased amplitude. Vocal intensity is moderately decreased also, and the client's subglottal pressure and phonation thresher pressure are above normal limits, and his maximum phonation time is low for men his age. The EEG results show a long open phase and a short closed phase, which is consistent with his Cape V results, breathy voice, and high subglottal pressure, mirroring airflow and PTP. The EMG showed low activity in the lateral cricoid arytenoid, which is responsible for vocal fold adduction. The stroboscopy revealed an incomplete glottal closure and thinning of the mucosal membrane and aperiodic vocal fold vibration, as well as an asymmetrical phase symmetry. VP would like to resume his normal activities with improvements of this voice. VP's moderate physical effort, emotional distress, and frustration are a result of his voice quality. The clinicians believe that hypofunctional voice is possibly due to damage to the recurrent laryngeal nerve about 8 months ago with a conjunction with his presbyophonia. Based on objective results, subjective analysis, and medical history, we believe that VP presents with a unilateral vocal fold paresis caused by damage to the recurrent laryngeal nerve.
So based off of VP's diagnosis, his treatment goals are reflective of how to aid to best use his voice. So he is going to decrease laryngeal tension, improve diaphragmatic support, decrease breathiness, increase vocal endurance, and increase loudness. The client will be able to eventually rate his laryngeal tension to a 2. He will improve his diaphragmatic support to reading 2 phrases with 6 to 13 syllable sentences. He will be able to decrease his overall breathiness when describing an object. And he will increase self-awareness by providing ratings of vocal endurance. And then finally, he will increase his loudness to 70 dB. So the rationale for the goals are that with VP achieving relaxation of his laryngeal musculature, that he will be able to aid in his voice problem of tension, and that diaphragmatic support is an important aspect of voice therapy. So he will have adequate breath support. He has a complaint of breathiness, so we've noticed that through a loss of air, he has breathiness, and so we will be working on breathiness. And for vocal endurance, we're going to build up the endurance that may be caused from his muscle fatigue. And then finally, we will try to increase his loudness to normal limits, which is about 70 to 80 decibels for men.
So the intervention options, the approach and procedure. So we decided to do the LMT and the MCT. And these goals will help reduce any tension and promote relaxation. These exercises were chosen based on the complaints of our client of having an effortful voice, and that's causing tension in or around the vocal mechanism. So this will help relax, the laryngeal massage will help relax the tightness of the vocal tract muscles and improve the range of motion. Next, the effort closure and chant talk. So the effort closure will decrease the breathiness that our client is experiencing. This technique will also be paired with the chant talk, and this will also help with the forceful adduction of the vocal folds. And the rationale for both of these is that it's going to help with the muscles being contracted and the voice production to become more efficient. Next is the LSVT Inspire tasks. These will help our client produce the client's volume easier. These will increase the amplitude and strengthen the larynx throughout frequent exercises and also target loudness. Generalization, so conversation monologue training. This will also have increased background noise to help with the environments that our client is frequently in. And this is a principle that is learned one behavior in a particular environment and then carried over to the next. A home program, we had mentioned that a paper copy sent home with stimuli and materials, and maybe like an audio tape, but no electronics like involving a computer for our client given his age. And this kind of program with behavioral and lifestyle changes will increase progress for our client. Intervention. So recommendations for VP are for him to attend voice therapy for 50 minutes once a week with a speech language pathologist. If he's able to make progress on his goals with his treatment schedule, it is recommended that he switch to longer sessions if he maximizes his threshold of his vocal endurance during these 50-minute sessions. The clinician will just adjust the treatment as needed, and also primarily focusing on that patient-centered care. So this is broken down: beginning of the treatment, session 1, week 1, middle of the treatment, approximately week 2 to week 6, end of treatment, generalization weeks. So the beginning of the treatment will be welcome to voice therapy, build the rapport, introduce the techniques, have a VHI completion, home program is introduced but not sent home. The middle of the program, build rapport, discussion of the VHI, continue to work on treatment and progress through the sessions, working on modeling and negative practice. And the end of treatment is really focused on generalization and how it's primarily targeted. So as you can see, we kind of broke it down by minutes. So he's going to have rapport with the client, decrease laryngeal tension, strengthening breathing for the voice, the 6 to 13 syllables with diaphragmatic breathing. Next, the client will increase vocal endurance with a rating scale, will increase loudness to 70 dB with LSV inspired activities, and then end with homework and conclusion.
So here is an example of how we would collect session data. And as you can see, there are some stars indicating that he has met criterion. So we would just move through the goals, and then once he reaches his goal, that'll be good. And so here's his outcome data. As you can see, he improved roughness, breathiness, strain. His volume was more appropriate. So overall, he made some good improvements. Here is his acoustic data. He, as Annabelle mentioned earlier, his jitter was below normal limits, but post-treatment and is now within normal limits. He made improvements in a lot of areas, but maybe not quite as much, just as he could have due to his age. And then the same thing for the aerodynamic data. You can see his pre-therapy numbers and then his post-therapy data. And then his clinical discharge statement. So he was a 70-year-old man post-thyroid surgery, presented with moderate to severe breathiness and roughness, a moderate decrease in amplitude. He received a medical diagnosis of significant nerve damage and nerve impairment to his recurrent laryngeal nerve. And this seemed to impact his emotional state as a result of the effort it required for him to produce his voice, and it was coming out breathy and quiet. During the 6 months of voice therapy, we focused on diaphragmatic breathing, laryngeal tension, breathiness, vocal endurance, and loudness. And his moderate to severe breathiness and roughness was significantly reduced. So he's currently only exhibiting mild breathiness and roughness, like we saw in the CAPE-V post-treatment measures. He's described his voice as much more natural. It's louder, stronger, and not quite as airy. He also reports that the emotional distress he was experiencing has decreased since his voice has gotten better. The prognosis for his maintenance of gains appears to be positive due to the breathiness and roughness only being mild, as well as how committed he was to completing the home program. He reports that his quality of life has been significantly improved and his voice overall, he feels has greatly improved. So it's recommended that he continues to generalize the voice therapy techniques he has learned and contact the clinic if he has any questions or concerns going forward.